Welcome to the MRCpology channel for a quick review, understanding, and revision of the topic. Imagine an immunosuppressed patient who develops progressive weakness, visual symptoms, ataxia, or cognitive decline over a few weeks. There is no fever, no meningism, and no dramatic raised intracranial pressure. The MRI shows multifocal white matter lesions, but they do not behave like abscesses or tumors. This is the clinical space where progressive multifocal leukoencephalopathy, or PML, becomes an important MRCP diagnosis. PML is a subacute demyelinating disease of the central nervous system caused by reactivation of JC virus in immunosuppressed patients. The key words are progressive, multifocal, and leukoencephalopathy. Progressive means it worsens over days to weeks. Multifocal means it affects several regions. Leukoencephalopathy means disease of the white matter. To understand PML, think in 3 steps. First, JC virus is usually acquired silently and remains latent, especially in kidney and lymphoid tissue. Second, when cellular immunity is impaired, the virus can reactivate, enter the bloodstream, and reach the brain. Third, JC virus infects oligodendrocytes, causing lytic oligodendrocyte injury and patchy demyelination. That pathophysiology explains the imaging. Oligodendrocyte destruction causes white matter demyelination. Because this is not primarily a tumor or abscess, there is usually little mass effect, little edema, and often no enhancement. So the classic MRI pattern is multifocal, asymmetric, subcortical white matter T2 or flare hyperintensity, often T1 hypointensity, with little or no enhancement and little or no mass effect. The typical risk settings are advanced HIV, hematological malignancy, transplant immunosuppression, and immunomodulatory drugs. In MRCP questions, natalizumab is especially high yield, but rituximab, fingolimod, dimethyl fumarate, and other immunosuppressive therapies can also be relevant. Clinically, PML causes progressive focal neurological deficits. The patient is usually afebrile. The deficits depend on where the demyelination is. If corticospinal tracts are involved, there is weakness and upper motor neuron signs. If parieto-occipital white matter is affected, the patient may develop visual field defects or cortical blindness. Frontal and subcortical involvement can cause cognitive decline and behavioral change. Cerebellar or brainstem disease can cause ataxia, dysarthria, and cranial nerve signs. Seizures may occur when lesions are close to cortex. The key clue is progression without the inflammatory features you would expect in meningitis or encephalitis. Headache, fever, meningism, marked edema, and raised intracranial pressure are less typical. Their presence should make you broaden the differential. Now, let us connect the MRI differentials to the image shown here, because this is where exams often test pattern recognition. In PML, look for multifocal asymmetric subcortical white matter lesions on flare. They are often bright on T2 or flare, dark on T1, and typically show no significant enhancement, no restricted diffusion, and no major mass effect. This fits the biology: demyelination without a bulky inflammatory mass. Do not confuse this with an MS relapse. In multiple sclerosis, the lesions are usually in typical locations: periventricular, juxtacortical, infratentorial, or spinal cord. They are often ovoid, and active lesions may enhance after contrast. The MRCP trap is a patient on natalizumab with new neurological symptoms. That may not be an ordinary MS relapse. It may be natalizumab-associated PML, so the MRI pattern and clinical course matter. CNS lymphoma is different. It often appears as a solitary or multiple deep white matter lesion, commonly periventricular or involving the corpus callosum. It usually enhances strongly and homogeneously, and it often shows restricted diffusion because lymphoma is highly cellular. So if the scan shows a deep enhancing mass with restricted diffusion, lymphoma moves up the list rather than classic PML. Toxoplasmosis is another important mimic, especially in advanced HIV. The MRI pattern is multiple ring-enhancing lesions, classically in the basal ganglia or corticomedullary junction, often with edema and some mass effect. The ring enhancement reflects focal necrotic infection with surrounding inflammation. So the key contrast is this: toxoplasmosis gives ring-enhancing mass-like lesions. PML gives non-enhancing or minimally enhancing demyelinating white matter lesions with little mass effect. HIV encephalopathy produces a more diffuse and symmetric picture. Instead of focal asymmetric lesions, there is bilateral symmetric white matter T2 or flare hyperintensity, often with cerebral atrophy and ventricular enlargement. The mechanism is diffuse HIV-related brain dysfunction rather than focal JC virus demyelination. So HIV encephalopathy is usually global, symmetric, and associated with cognitive slowing, while PML is focal, asymmetric, and progressive. CNS vasculitis gives a vascular pattern rather than a demyelinating pattern. MRI may show multifocal ischemic lesions in multiple vascular territories, sometimes of different ages, and there may be microhemorrhages on susceptibility imaging. The clue is territory-based injury, infarcts scattered across different vascular distributions. PML does not usually respect arterial territories. ADEM, or acute disseminated encephalomyelitis, tends to show large, poorly marginated, bilateral white matter lesions, often asymmetric, and enhancement can be variable. It is usually monophasic and often follows infection or vaccination. In exams, ADEM is more common in children and younger patients, but adults can be affected. Compared with PML, ADEM is more inflammatory and acute or subacute, often with encephalopathy. PRES, posterior reversible encephalopathy syndrome, has a very recognizable pattern. It causes symmetric vasogenic oedema, usually in the parieto-occipital regions. It can also involve the frontal lobes, basal ganglia, cerebellum, or brainstem. The clinical setting is important: severe hypertension, eclampsia, renal failure, sepsis, or immunosuppressive drugs. The key word is vasogenic oedema, not demyelination. So pre-S is often posterior and symmetric, while PML is usually asymmetric and multifocal. Drug-related leukoencephalopathy, such as with methotrexate or cytarabine, often shows diffuse, symmetric, confluent white matter T2 or flare hyperintensity, usually with minimal enhancement. Some patterns may spare U fibers. The history of chemotherapy or neurotoxic medication is the major clue. In contrast, PML is related to JC virus reactivation in the setting of impaired cellular immunity. Diagnosis of PML is based on the clinical setting, MRI pattern, and virological confirmation. MRI brain typically shows multifocal asymmetric T2 or flare hyperintense white matter lesions with little edema or mass effect. CSF JC virus PCR supports the diagnosis. However, a negative CSF JC virus PCR does not fully exclude PML if the clinical and MRI suspicion is high. Brain biopsy is reserved for uncertain cases where the diagnosis remains unclear. Management is based on one central principle: restore JC virus-specific cellular immunity. There is no reliably effective direct antiviral treatment. In HIV-associated PML, start or optimize antiretroviral therapy. The aim is CD4 recovery and improved immune control of JC virus. In drug-associated PML, stop the causative immunosuppressant. With natalizumab-associated PML, plasma exchange may be considered to accelerate drug clearance. In transplant or autoimmune disease, reduce immunosuppression where feasible, while balancing the risk of graft rejection or autoimmune flare. The major complication to remember is PML-IRIS. As the immune system recovers, it may mount an inflammatory attack around JC virus-infected lesions. The patient can clinically worsen, and MRI may show new enhancement or edema. This is not always treatment failure. It may be immune reconstitution inflammatory syndrome. Severe cases may need corticosteroids, but the balance is delicate. You want to reduce damaging inflammation without completely removing the immune response needed to control JC virus. If you remember one thing, remember this: PML is progressive asymmetric white matter demyelination in an immunosuppressed patient caused by JC virus, usually with little enhancement and little mass effect. The treatment is not an antiviral. The treatment is immune restoration. Quick recall: a patient with multiple sclerosis on natalizumab develops progressive visual field loss and limb weakness over 3 weeks. MRI shows asymmetric subcortical flare hyperintense white matter lesions with little mass effect and no ring enhancement. What is the most likely diagnosis, and what test supports it? The answer is natalizumab-associated PML, and CSF JC virus PCR supports the diagnosis, although a negative result does not fully exclude it if suspicion remains high. An advanced HIV patient has multiple ring-enhancing basal ganglia lesions with edema, while another has asymmetric non-enhancing subcortical white matter lesions with progressive focal deficits. Which diagnosis fits each pattern? The answer is toxoplasmosis for the ring-enhancing basal ganglia lesions with edema, and PML for the asymmetric non-enhancing progressive white matter lesions. Do subscribe to the channel for further videos.